Okay. Good morning, everyone. I am Kelly Caseman. I'm the Executive Director of Think Kids, and I'm thrilled to welcome you to Session 2 of the Health and Hunger Summit series. This is a virtual series where we will take a candid look at connections between the healthcare system and community resources that address hunger in West Virginia. Health and hunger are profoundly connected. Their systems should be too. You can find more information on our website, which is thinkkidswv.org, and on our Think Kids Facebook page. And we hope you'll join the discussion because more than ever in this moment, we need to unite in our efforts to ensure that all West Virginians are as healthy as they can be with access to healthcare and nutritious food. There are a lot of challenges to this, and so we are glad you're here with us today. Now, we know a lot more West Virginians than usual are on the internet right now, so if you get disconnected or have difficulties hearing, please know that this is being recorded, and we will share it on our social media sites probably this afternoon, but at the latest tomorrow morning. Also, you'll have the opportunity to share your thoughts and ask questions at the end of the panel discussion. So go ahead and type them in the Q&A or the chat box while they're fresh in your mind, and we will get to them at the end. And with that, we'll get underway by thanking our sponsor, Unicare, the Unicare Health Plan of West Virginia. Unicare is an American health insurance company owned by Anthem, Inc. They have been serving the West Virginia Medicaid population for over 20 years in our state, and they have been a wonderful partner of mine on several projects over the years, ensuring that kids have access to comprehensive health care, and so we really appreciate their support. Our first presenter is Dr. Kimberly Becher. Dr. Becher graduated from Sissonville High School, just down the road from me, here in Kanawha County. She obtained a bachelor's in biology from Denison University and worked in a breast cancer research lab at the University of Cincinnati. She attended medical school and family medicine residency at Marshall University, where she concurrently completed a Paul Ambrose Health Policy Fellowship. She served on the American Academy of Family Physicians Board of Directors as a resident physician. She received the 216 Rural Health Provider of the Year Award from the West Virginia Rural Health Association. She works at Community Care of West Virginia in Clay, where she focuses on health disparities, social determinants of health, and transgender care. She is currently on the board of directors of Mountaineer Food Bank and Clay Senior and Community Services. Thank you for joining us today, Dr.
Hello, can you guys do thumbs up? Can you hear me okay? Excellent. All right. I will start with a disclaimer that of the webinars I've done this summer, I have been dropped a couple times due to my internet connection. So if that happens, Kelly, I will get right back on as soon as I can. And I apologize in advance if it does happen. I don't have a PowerPoint presentation, partly because I'm really not giving you guys data. I am telling you a story about my experiences here in Clay. It's kind of like, I would call it kind of like the physician's grassroots guide to food deserts in West Virginia. I came to Clay. I'm just starting my 7th year here with community care in Clay. It's a federally qualified health center, which becomes important when you want to think about things that we do and the ways that we do things to address food, because we are eligible for some grant funding and things along those lines. This organization was attractive to me as a physician coming out of residency because they were willing to take chances. They were willing to try things, to do little interventions, you know, that maybe we weren't going to get reimbursed for. Maybe those things cost us money, but if they improved patient outcomes, this group was willing to do things like that. And that was important to me coming out of residency. I wanted to work at a place where I could see people without insurance and take all insurances. So that's how I got here. So I'm not from Clay. I didn't know anybody in Clay. So I was new to the area, and within the first year that I was working here, we lost our grocery store. So, you know, as a primary care doctor, you're always talking to people about, I mean, you're talking about nutrition, especially with children, But with adults, you're literally asking, what did you eat this morning if they have diabetes, or if they're having a heart failure exacerbation, or if they want to work on weight loss. So losing that grocery store within my first year really kind of forced the discussion to open up about food in this community. So we had 3 options really for buying food: Go-Mart, the dollar store, and Rite Aid. And then we had restaurants. We have a diner, we have a Subway, a Tudor's, and a Geno's, because we're in West Virginia. We have to have those. And that was it. And you know, if you're really trying to stretch your money and pay for food over the course of a month, you actually can't afford to eat at Tudor's every day. Thank goodness, because I want people to eat at Tudor's every day, but it's more financially limiting than you would think. So, you know, we had that year with no grocery store, and that started the discussion. But luckily, you know, about a year later, we had another store open back up. And thank goodness it was open before the flood in 2016, because that further impacted our food access issues in Clay, because the Clendenin grocery store closed, which was the next closest store. So the store was open around the time of the flood, but then things started to look like they were going downhill. There were empty shelves. The produce prices kept going up. The selections were super limited. And there were rumors that they were going to close. So at that point, you know, I'd been here 3+ years, and we were doing social determinants of health screenings. So we were asking our patients, do you have trouble accessing food? Do you have stable housing? We were asking those questions. So the combination of asking questions about social determinants and the fact that I'd been here for a few years, you know, I was getting an idea of just how detrimental it would be if we had no store. And I kind of went into panic mode, and I tried everything I could to keep the store open. I called the people managing the store. I called the people that own the building. I've got a bunch of people together. I'm sure some of you that are listening to this webinar today were part of that group, because I had a lot of people involved with just coming up with ideas for how to save a grocery store in a community. We had reached the point where we could offer like economic analyses to the people that were considering opening it, grant money, all sorts of stuff, but it never really took off, obviously, because we still don't have a store. And it kind of led to this depressing realization as we kept having these meetings and bringing a lot of different people to the table, that what if this community can't support a store? What if we have a situation where the people that have transportation are going to choose to go somewhere like Flatwoods or Summersville or Charleston, and the people without transportation, they can't support a store on their own. So without transportation, it created this have and have nots kind of situation in terms of grocery store support. And that was sad, and we still don't have a store, but I'm going to switch gears a little bit and come back to what we're doing to get people food after I talk about what we actually physically do in the office to screen for food insecurities. So, like I said, social determinants of health. I'm going to talk a little bit about what exactly we ask patients and then how we address their positive responses to those questions. Twice a year, we can ask these questions more often, and we often do. If we know that there's been a major change in someone's economics or living situation, we'll ask the questions more often than twice a year. But at a minimum of twice a year, we ask the following questions. We ask the patients if they've been to the emergency room, if they have a steady place to live, if they worry about running out of food, if they are unable to buy food, if they lack transportation, if they worry about or have had their utilities shut off, if they feel threatened, if they feel like they're the victim of any physical or emotional abuse, if they have, and these two are a little trickier, if they have trouble running errands, or if they have problems with their memory. So that's a pretty big umbrella of things that we touch on as we ask those questions. And if the patient has insurance, we then enter those responses into a database called Capgate. And that company reaches out to people and offers solutions, you know, certain community resources, but they tend to not be Clay focused, you know, that's coming from Charleston or statewide. If they're not insured, then our own staff reach out to them and see what we have to offer. For example, that person might only, you know, say, hey, if you have a challenge, you should call United Way's 211 and see if they can help you out with this or that. Or occasionally, and I'll get into this in more detail, I have written quite a few grants to address some of these positives. So sometimes it's one of our staff reaching out, and then when they really dig into the details of what's going on, find out that, you know, they can't pay their mortgage and they're going to get evicted. And maybe we pay their mortgage. So it's specialized to each patient, you know, what resources they end up getting and who calls them. But everybody gets followed up on if they have a positive response to any of those questions. Now, we do get paid for asking those questions if they have insurance, but it's only $1 twice a year. So obviously we're not doing it for the dollar. We're doing it because it changes outcomes. So some people do get offended. Some people get upset when we're asking these questions. And often people will, especially early on, they'll lie. You know, they'll say that they don't have any problems with food access and that they've never had a utility shut off. But then as I take the time to really explore why their blood sugar is 400 and why they've gained 80 pounds and why they haven't filled their insulin, even though they tell me they're using it, you know, there's this real honest moment that you get to where people have to be honest with you about what resources they do not have. And it takes reaching that point, gaining their trust so that they trust you enough to tell you how they're living their lives that they may be embarrassed about. They may be worried, you know, if they have children, they might worry that I'm going to call CPS. So it's got to be this relationship where I can only help them as honest as they'll be with me. And they have to trust that I'm only asking these questions to help them achieve better health for their families. So there's a term that I have stolen from someone on social media. I have no idea who it was. It was someone in West Virginia. I'm hoping they're on this call and they will out themselves as the person I'm stealing this from. But somebody called this area a food swamp, and it's a perfect term. We have all the canned pork and beans and ramen noodles that you could ever want, but we don't have meat and produce. We don't have the food that you need if you're diabetic or you have heart failure. We have plenty of carbs and plenty of calories, but we don't have quality food. And that is a major distinction that I have to get patients to understand. They might not worry about running out of food, but that's because they're not buying high quality food. And I need them to be able to eat and obtain higher quality foods for me to be able to make them healthier, for me to make them have a longer life with less morbidities, to be able to lower their medication costs. If I can get them better food, they won't have to be on as much insulin. They won't gain as much weight. And that's really that like aha moment when I can get people to understand that I'm not trying to criticize what they're eating. I'm trying to lower their insulin dose. I'm trying to, you know, make them feel better, wake up with more energy. And Clay is a very proud community. A lot of times, especially right around the flood in 2016, we would reach out to people and offer to help them with, you know, say, buy a new washer if they lost their washer or their stove in the flood. And people would literally say, people with nothing, people sleeping under a tent on a church pew would look at me and say, that person down the road needs your help more than I do. And that's been a barrier. You know, it's hard to help people if they feel like, no, I'm okay, you know, like this. And so we've come a long way because number one, people have to trust you. And two, if you're going to provide a solution or an intervention, it has to be something that actually works for them. You know, I can't give them a gift card to Kroger if they can't get to Kroger. It's got to be an intervention that works for their living situation. So that led me to try to come up with some solutions at my own community and county level. You know, if you read about social determinants of health on a more national scale, there are a lot of criticisms to doing the types of interventions I'm doing because they're very individually targeted. I'm helping people one at a time, whereas there are a lot of there's a lot of dialogue about how this needs to happen from the top down. We need a living wage. We need a you know, a different structure for a lot of things. However, I'd love for those things to happen, but I really couldn't go through these exam rooms day after day and see patients that I didn't feel like I was helping achieve their goals, because they're their goals. They don't want to have an A1C of 15. They want to live longer. They want their diabetes to go away. So I started just literally asking anybody I could to help me help my patients. So I have now had a series of grants. I meant to tally up how much money and grant money I've gotten over the past few years, and I forgot to do that. But, you know, I started to see that if I have somebody with diabetes or COPD and they don't have electricity, then they can't run their oxygen, they can't do their breathing treatments, they can't refrigerate their insulin, they can't buy as much meat and produce, which is what they need to be eating, because they don't have a way to store it. So I kind of thought, you know, if I pay their power bill, their diabetes is going to get better. And so I started doing things like that. And it's really been eye-opening. People have quit smoking just because I helped get their electricity turned on. It's just been interesting, the positive outcomes that I have seen. And we have a community health worker also, and she is great at, you know, sometimes there's a challenge a patient has that I can't figure out, or maybe it's not something I can address with a grant. And people have to understand, once I get the power on, what do they need to buy? Let's say they're going to go in GoMart and get their groceries for the week. What can they buy there to not shoot their sugar up? Or what can they buy there that's going to be better for their weight loss goals? And she has been great at figuring out where the gaps are between what I'm saying and what the patient is hearing. For example, a lot of patients really and truly believe if they toast their bread and it's brown, it's as good as wheat bread, or it somehow has fewer, it's not going to raise their sugar as much. Things like that, that like she can get these conversations out of people that maybe I don't. So it's been fun, you know, to see these things escalate. So, so one thing, when we're screening for food insecurities, that's the complicated issue. And that's the thing that I struggle with. Even though I've now got some resources to offer people, I still struggle with really getting people to identify as food insecure. So now back to the no grocery store. So we still don't have a store. The Mountaineer Food Bank and the United Way have been doing mobile pantries for the past two years, year and a half. At one point we were doing every 2 weeks, and we would have a tractor trailer at the high school, and a group of us would go down and literally load cars with food. And there were families that I know were existing just off of that food. And it's high quality food. If you've never been to a Mountaineer Food Bank event, you know, it's produce, it's meat, it's good stuff. Sure, every now and then there's something that I don't want to give the diabetics, but overall, I'm really impressed with the quality of the food that we give out at those events. And usually in Clay, we'll have about 1,000 people served, which is about 10% of the county. It's usually over 300 families will receive food at one of those events. And, you know, when the patients see me out there doing these food distributions, and then they see me in the office after that, there's this different level of honesty that I get from them about food, and about what they do with food. It's not just what they eat, it's what they do with it, which is really interesting. People don't waste anything. You know, I don't know how many patients made plum jam when we gave plums out one time because they just couldn't eat them all. They freeze things, they process things so that everything ends up being used because they really value this service, this food that they're getting at these events. Now, another thing that we've had happen is we had a produce and a meat market open in Clay. It's called the Small Town Market, and it opened, unfortunately, right at about the start of the COVID pandemic. So I remembered, you know, back when the grocery store was open, a lot of patients would say, oh, they're too high. I don't go there. I can't afford their produce, or I can't do this or that. And so I wanted to make sure people actually gave it a chance and they went in there. So I wrote a grant, kind of a COVID relief grant, to give people food vouchers to go into the market. And they're $50 vouchers. I'm pretty sure have given all of them out as of last week. And I thought it might help with the startup costs because it was so hard to get anybody to open anything with some quality food in Clay. So I wanted to make sure we were supporting them as a business trying to provide healthy food options. And then two, I wanted to get the people in the door to see what they could get with $50. I thought that would help keep them going back there. Now, it's it's been really interesting. Unfortunately, some really sad stories have come out of that particular experience, in that I had one lady, multiple people have just cried when I've given them the voucher. When I say, you go in and you pick out $50 worth of food. Like, they haven't been able to do that for a while. It's somewhere that they can get meat and produce, or they've just been getting food from food pantries. And so to go in and pick out what they want, I had a lady just cry because she had only eaten raisins for a week. These are things we don't think still happen in this country or in this state. And this is how people are living. And when you give them this little, window of enjoying some other foods, it's really eye-opening. Now, we have that market. We're still doing the food distributions once a month right now. But I haven't really, I may have given up on thinking that I can get a big grocery store in here, but I haven't given up on coming up with new ideas to try to bring healthy foods to Clay. I am kind of in the discussion phase of trying to work with Margaret O'Neill, who was one of the panelists on the first segment of the summit, about a mobile grocery store idea. Transportation is a huge challenge here. How do we bring the food to the people so that it's more accessible to them? If we can't support a big store, maybe, we can support tiny communities one day a week. So those are some ideas we're throwing around now. And the thing that I've learned through this process, number one, I know nothing about running a store. Learned that really well trying to have these conversations when we were losing the store. Every community has different needs. And as I've been here longer, I've started to understand more what Clay's needs are in particular. And then two, as people have started to identify me as somebody who does, push for them, I advocate for them. I don't live in Clay. This isn't my grocery store. So I'm advocating for them, trying to get food for them. They're more honest with me, and they'll tell me things that they wouldn't tell me before. And that's huge. It's made me more effective at advocating for them, and more successful. I get more buy-in in terms of the patients for their diabetes control and things along those lines. But I think my take-home message for anybody who's a healthcare provider who's listening to my what I called my grassroots approach is you just never hesitate to ask for resources for your patients. Even if you think it's some outlandish thing that no one is going to help you do, they might. And sometimes it's outlandish things that you need to ask for to get your patients something as simple as food, or to get them a freezer. But I don't feel like I'm doing my job if I'm not addressing the barriers people have to accessing the care that I'm trying to prescribe. And that's what keeps me motivated to keep doing these things too. So that is all I have to say, but obviously I'll be happy to answer questions. And luckily the next two panelists are actually going to give you data about why these things are important.
Thank you so much, Dr. Becher. That was awesome. And if I see that we have some questions in the chat box, which is wonderful, and we'll get to them at the end of the session. So with that, I'm going to introduce Dr. Rafka Chaiban. Dr. Chaiban was born and raised in Lebanon. She moved to the United States about 10 years ago after she completed her medical degree at the University of Balamand in Lebanon. Her career path started in Boston as a research fellow at Children's Hospital. She completed pediatric residency at West Virginia University Hospital in Morgantown. She worked as a pediatrician at the NICU hospital and NICU hospitalist, at the Eastern Panhandle of Berkeley Medical Center for 4.5 years. She transferred back to Morgantown to assume a new role in the community practice department about 3 months ago. Currently, she is studying for a master's degree in healthcare management at Harvard University, where she will graduate in May 2022. Welcome, Dr. Chaiban.
Hello, good morning. Can you hear me? Thumbs up. So I'm going to discuss food insecurity and child hunger. I have nothing to disclose except that I advocate for kids. I confess that I don't screen for hunger. And that's why I prepared this presentation. I learned a lot, and I'm very excited to share this information. I will approach this topic by defining some terms, effects of child hunger on health, screening and connecting family to resources. Also, I will discuss food insecurity from public health standpoint. We are the people who are gonna connect the puzzle together. What is food insecurity? It's a lack of nutritious food in sufficient quantity to maintain good health. It's lack of protein intake such as meat, poultry, eggs, beans, and peas. It's lack of fresh fruits, dried or canned but not juiced, and lack of vegetable and lack of dairy intake such as milk and butter and cheese. Food insecurity and poverty goes hand in hand. The impact of poverty and food insecurity is detrimental on health, development, and well-being. West Virginia ranks 44 in poverty rate at 17.8% compared to the national average of 14.6%. This was in 2018. In 2019, the percentage is 16%. If you look at this graph, it shows the rate of poverty by age. And you can tell that our children and adolescents in poverty, and West Virginia ranks 46 for children and adolescents in poverty in 2019, according to the America's Health Ranking. 5.6 residents of West Virginia live in poverty. Please take a look again at this graph and see that our population, the population that I take care of, are at higher poverty rate. This is another graph to show you the rate of poverty based on county. The best states in terms of poverty, if I can say that, is Jefferson, Morgan, Putnam, and Grant, and these are the blue colors. The poorest are Mingo and Wyoming, and these are the poorest counties in the state. So food environment is associated with health. What are food deserts that Dr. Becher said about? These are geographic areas with limited food access to affordable, healthy food. The other thing is healthy food access is characterized by accessibility, availability, affordability, and acceptability. Availability of a supermarket is used as a proxy measure of healthy food access. On the other hand, the other definition is the food swamps, and these are geographic areas that are saturated with fast food outlets. Let's click on the first link to explore the USDA Food Environment and Food Access Atlas.
Can you see it? Okay. Hold on just a tick.
So this is like this, the United States. Let's zoom into West Virginia. If you click on the counties, like let's pick any county. This is like Pocahontas, and this is like in 2011, there was one fast food restaurant. In 2016, there was an increase by one other fast food restaurant. If you can access these links whenever you want and just go and check different counties, how many fast food restaurants and the change from 1 year, from 2011 to 2016. The more access to fast food restaurant, the worse the healthcare outcome. We're gonna go back to the presentation. This is another link, but we're not gonna click on it just for time. But I took a screenshot of it and I want to show you. This is also, you can access all the states in the United States. In West Virginia, this graph shows you the low-income census tract where a significant number or share of residents are more than 1 mile or 10 miles from the nearest supermarket. Another measure that you can look at, this is how the low-income census tract where more than 100 housing units do not have a vehicle, or a significant number of residents that are more than 20 miles away from a nearest supermarket. So no supermarket means no access to good food and no vehicle to go and get the food. What's the impact of hunger on children? Children 36 months and younger have poor overall health and are more hospitalized than other patients. Children 4 to 6 months old are at higher risk of developmental problems. Iron deficiency is one of the effects. Even low prenatal iron, like mothers with low iron intake, this will cause poor performance on language comprehension and inability to follow direction over the first 5 years of a child's life. There will be a delay in socio-emotional cognitive motor development. There will be persistent symptoms of hyperactivity and inattention 2 times fold from kids who are not iron deficient. There will be poor memory and hyperkinesia and lower bone density in pre-adolescent boy. This child is irritable, and this is one sign of iron deficiency. Children 36 months and can you go forward? One more slide. Continuous exposure to toxic stress mean like families are always living in a toxic stress because they cannot afford a meal. And this will lead to depression and anxiety. Also, another effect is dysregulatory behavior. Hunger is a predictor of adolescent depression and suicidal ideation. There is also low cognitive indicator and low academic achievement. There is a positive association between food insecurity and childhood obesity, and this is because of limited access to high quality food. And there is also usually an unhealthy eating pattern due to the stress. And also I would like to add the dental cavities associated with poor intake of healthy food. Some families do coping strategies and they might dilute infant formula, and that's the reason why you see like poor growth of a child. And one question you could ask, how do you prepare your formula? Foregoing food needs for special medical diets, purchasing low-cost diet that relies on energy-dense instead of on nutritious-dense food, making trade-off between food and other basic needs. We cannot tell by looking who is hungry and who is not. I want to ask a question. Do you screen for hunger in your clinic? Can you please pick an answer?
We've received 8 responses so far. So we'll give, about half a minute more, and then I'll share the results.
If someone just can write down for me, what do you mean by sometimes? Okay.
we won't be able to see what they write until the end of
Okay. Okay. I'll comment on it later. I asked the same question when I prepared this presentation to few pediatricians in West Virginia and to family medicine doctor. And I had like 6 responses of they don't screen. And this is one of the major things. We don't screen for this question. This is the Hunger Vital Sign, is a toolkit that the FAAP recommend to screen for food insecurity in your practice. You can do this at every well child check visit. The questions are, within the past 12 months, we were worried whether our food would run out before we got money to buy more. The second question is, within the past 12 months, the food we bought just didn't last and we didn't have money to get more. A positive screen is any answer that is often true or sometimes true to either one of the questions. You can diagnose and code it. This is like a positive screen, and the diagnosis code is a lack of adequate food and safe drinking water. What do we do next? Refer, connect to SNAP and WIC? I already don't know how to do that. I don't have enough information sheet or reference sheet so I can pull in patient chart to send them, to give it to them at the end of the visit. I think most of us are not prepared to screen for something we're not aware of. We know about child hunger, but we don't know what to do. So Hunger Vital Sign is already built into the EPIC Foundation system. I went through EPIC and looked for the hunger screening in our EPIC NWVU. These are the nutrition questions they ask, and no question regarding hunger or food insecurity. I looked at the quality targets and measures. These are quality targets that come from Medicare and Highmark. The higher the performance, the larger quality bonus the organization receives. If you look at it again, Hunger Vital Sign or screening for hunger or any toolkit is not present. I just wondered why screening for hunger and food insecurity is not one of the metrics in our poor state. We don't need to fix everything. We need to educate our pediatrician, nurses, nurse practitioners, social workers, or educate ourselves. We need to implement screening and intervention and let it be an organization and West Virginia wide. Food insecurity is a sensitive subject. Parents may be reluctant to talk about this issue in front of their children. They want to protect them. Don't forget the stigma we talked about in the first session. Intervening is the key. I want to say a well-groomed and well-dressed child does not mean food secure. Obesity does not mean food secure. Embedding Hunger Vital Sign in our EMR or any other medical records, electronic medical record is one of the approaches. Do quality improvement projects, and I'm willing to do that after I looked it up. Incorporating social worker in our clinics. We are a state with poor resources, and having a social worker will help all the physicians around, not just one or two, to make sure that every time we do a referral or we recommend something, this goes through. We need to connect family to the federal nutrition program. It is our job to talk positively about the federal nutrition program. We need to create a sustainable intervention model. This is not just one-time thing or one-year thing. This is an ongoing thing. We need also to change. We need to do healthy food environments that are accessible, available, affordable, and acceptable. For change to happen, there should be equitable access to healthy food. Healthy food financing initiatives that target policy makers to target development, renovation of healthy food retail. Opening of new sources of healthy food such as supermarket and grocery store will increase overall economic activity. Using scientific evidence to translate evidence to policy. I want to say access does not mean demand. So placing supermarket in a food desert may not be enough to drive utilization. The goal is to reshape the local food environment and to encourage the community the demand for this change. We need to educate the community about healthy food. These are my references, and thank you.
Thank you so much for joining us, Dr. Chaiban. I really appreciate your time and your input today. And I would like to introduce our final panelist today is Dr. Jessica Wooten. Dr. Wooten is a board-certified family nurse practitioner with special interest in public health, including immunization and family planning. She holds a master's in nursing and a doctor of nursing practice from West Virginia University. She is also a dedicated inclusion and equality advocate, currently serving on the board of directors of the Down Syndrome Network of West Virginia, the Wood County Society, and the medical outreach team of the Down Syndrome Diagnosis Network. Thank you for joining us today, Dr. Wooten.
Thank you for having me. I am going to try not to repeat too much of what the other doctors have already said, but a little bit of background about health and hunger, food insecurity. Food insecurity can contribute to or exacerbate nutritional deficits, and that's linked to chronic diseases and chronic conditions. And we know that research is across all income groups. So it can be especially true in people who are at the poverty level, but nutrition affects chronic diseases and conditions across the span. So when we talk about food insecurity, I think it's important to think that we're really talking about two separate things. One, do you have access to enough food? But two, do you also have access to nutritious food or food that is what you need if you have a specific disease process, say like diabetes? Like Dr. Becher said, you can go to Dollar General and get ramen noodles and lots of canned things. You may have access to enough, the right amount of food, but not the right types of food. One thing that's important, Kelly, will you go back one slide really quick? I just want to say a couple things that are important with when we think about hunger and how it affects our patients, especially children. It can exacerbate chronic disease if you don't have the right nutrition, but also toxic stress can be really important, especially for our kids. If our children, especially school-age children, are worried about where they're going to eat that night, or if they have food for the weekend, they're not thinking about reading a book or doing their homework because, you know, their focus is on that meal, that unmet need. And food insecurity is also statistically tied to healthcare utilization. So when we look at research done on people that don't have the correct access or the amount of access they need to food, they actually are utilizing the healthcare system more, usually emergency rooms and things like that, acute care. And when we think about our patients' access to food, we're also thinking about, can they obtain the food? But then if they can obtain food, what can they do with it? Do they have the utilities to cook? Do they have refrigeration? Do they have a freezer? Do they have a stove? Can they read? Can they read a package label? Can they read a recipe? And of course, transportation is always important, especially in this state when we don't have a lot of access to public transportation. You can go ahead, Kelly. So why aren't we screening for hunger? Well, there's a lot of reasons. There's not a good excuse. The American Academy of Pediatrics recommends that we do screen for it in all of our patients, but it's just like everything else. It takes time to kind of get it into your repertoire and make it a habit. One reason a lot of providers don't is lack of time. You only have a set amount of time with a patient. That time is usually small and not as much as you would like, and you're trying to fit everything into that, and a lot of times it just gets missed. Some patients don't have access to primary care or are utilizing clinics and ERs, things like that, so they don't have a dedicated provider that's checking their social determinants of health. A lot of providers, especially rural health providers, FQHCs, are looking at being required to do multiple screenings that are tied to funding, things like BMI and hospitalizations. This hunger or nutrition screening is not always tied to funding, so then you don't always have the support of administration reminding you that you need to do this, making it a priority. As Dr. Chaiban said, malnourishment is not always apparent. We can't always just look at a patient and say they are malnourished. They don't have what they need. So it's not always a visual thing. And then specifically for my practice, but also for the state, is a lack of care coordination. We just don't have it at a lot of places. And so even if you get the screening, then where do you go from there? Where's the next step? Dr. Chaiban also mentioned the hunger vital sign. This is has been approved by the American Academy of Pediatrics. It was developed in 2010. It's a validated 2-question food security screening tool. It was based on the U.S. Household Food Security Survey module. And it's basically 2 simple questions you can ask in your practice. And then if they answer yes to these, then you go on to get more detail in your screening. So for my personal practice, Kelly had mentioned in a Facebook post or something a long time ago, do you talk to your patients about food access? And when she asked that, I thought, no, like I'm not doing that. And from that day forward, my nurse and I talked and we said, how can we make this a part of what we're doing? Our electronic health record does not have a clear screening. It doesn't have that hunger vital sign in it. So we had to find a way that we could document it in our patients' charts. And what we did find was a place that we could chart, do you have access to enough food and clean water at home? And it's not perfect. It could be better. If they say yes, of course, there's lots of other questions we need to ask and information we need to get. But it's start and it's better than nothing. We do the screening for all of our patients, all ages, but we try to pay special attention to our elderly population who don't normally have enough access or transportation, and then of course children and families. And if someone says they don't have enough access, then we're looking at referrals. We have where I practice is in Jackson County. On one side of the county, we have Ravenswood. It has one grocery store. It's a food fair. It's a smaller grocery store. And the other side of the county does have a Walmart and a Kroger. So for some people, it's a 20-minute drive to access the larger grocery stores because they can't afford food at the smaller chains, especially produce. Grapes are like 3 times the price at food fair that they are at Walmart. So we have one food pantry. It's called the No Hunger Food Pantry. That would be our first referral. However, it's income dependent, and lots of people don't qualify income-wise. They'll be just above the line where they could get assistance. They still can't afford food, or they have extra people living with them, kids, grandkids, nieces and nephews. We can talk to school counselors. Our schools in this county are really good about paying attention to child hunger. We have a snack pack program where they send snacks and things home for weekends. In the past year or so, we've really been utilizing the United Way 211 service, where they can call and get, if you're not familiar with that, you call and they tell you what services are available to you. But then again, there's very little follow-up unless it's me personally. We do not have care management, case management, outreach coordination. So there's no one to follow up with that patient. Did you get access to this food? Did this help? Did it not help? Other ways we can help you. That's something that we're really lacking. And also fostering community partnerships. We have lots of organizations that could potentially address hunger. Schools, churches, some of these churches even have their own small food pantries, the United Way, other nonprofits, but there's not a lot of coordination sometimes between all the different organizations. So that's hard on a provider level. So what did we learn during the pandemic? Personally, in our practice, we learned that people are not food secure, and if they are, it's very dependent on, week to week. Do they have a job? Are their kids in school? Having kids out of school was a big deal here and across the state. Lots of people needed help feeding their kids breakfast and lunch. The schools here did a great job. They stepped up. They did meal delivery on school buses, or you could pick up meals at the school. They gave you a week at a time. They were frozen and fresh so that you could have access for later. One problem that we noticed with our food bank is they're, of course, entirely volunteer staffed, and the majority of that staff is elderly, retired. So when the pandemic hit, the food bank closed day one. And the volunteers said, we're not coming in, we're not risking our health for this. So when families needed access, the food bank was there, but it was closed. There was no one to operate it. SNAP benefits, if we saw that the state gave out about $300 per child in SNAP benefits, and that was really well received and people really utilized that, again, if they can get access to the grocery store. But definitely a big benefit getting those SNAP benefits. And then some of that meal delivery, like I said, they had to adapt where they were first starting having cooks make whatever they were making for the kids for lunch and send it home, to more frozen things that they could give out a week's at a time so that people had more options, more shelf stability, things like that. And like I said, they did that touchless and home delivery. The buses went to the bus stop and dropped off the boxes of food. So I wanted to talk about a couple things that some places are doing to try to step up and address hunger. This is the organization that I work for, Coplin Health Systems. They have received a grant for a FARMacy program where it's a prescription program where providers or nurses provide patients with a prescription for locally sourced produce. So the medical staff identifies people with needs that may be low income or food insecure and gives them a voucher to pick up fresh produce at our site at preset dates. It was a partnership through the Rural Action Plan in the Plains, Ohio, and the WVU Extension Office. And they worked with local farmers to get this. So that was an added benefit to the community. The partnership with the Extension Office also gives them the ability to provide information on how to prepare or store or preserve the food. So they can offer classes on canning and things like that. Because again, if we can get them access to food, wonderful, but can they use the food? When you're giving large amounts of produce, like Dr. Becher said, you can only eat so many plums. So can we do something with those plums? Can we can them? Can we freeze them so that they get a little bit more sustained access? They gave me a little bit of data to share with you. Not that you want to hear a bunch of numbers, but they when they started this program, they did some pre-testing, and about 25% of the participants reported that their diet was either fair or poor, and 80% agreed or strongly agreed that they could improve their health if they had better access to nutrition. 96% said that they would buy more fresh produce if they had the money to do so and the appropriate access to do so. And then they did a little bit of exit data. They've done this program at 2 sites or maybe 3 sites, and they're working on their 4th because they have sites in different counties. But 98% of people who received the bag of produce said that it definitely helped them increase the amount of fruits and vegetables they were eating. 59% said they learned more about healthy foods and could focus on healthier eating. And 94% reported that having the access and eating healthier had helped them feel better. They're not collecting specific data at this time about like decreased A1C levels or things like that, but it's exciting, and it's at least, you know, the patients have been really responsive and really enjoyed it. So it's an exciting program. And then finally, this is not an organization I'm part of, but if you're in rural health in West Virginia, you know that Williamson is just doing some really amazing things for their community. They have such a focus on health and wellness and healthy eating. These programs that they have are in collaboration with themselves, the Williamson Redevelopment Authority, and local farmers, again, locally sourced produce when they can, helping out farmers in the area. They have these veggie boxes that they send home. That's kind of like the FARMacy program. I think they have a mobile food market or farmers market. So it's not in a set location, but they take it to different businesses and things like that to give more people more access to it. They have a community garden. They do farm to table events. And the one thing that I really wanted to highlight again is these healthy living workshops, which have been centered around growing your own food, growing your own garden, maintaining and processing the food. So again, if you are given a large amount of a certain type of produce, that you can utilize it, that you could can it or freeze it, or, you know, keep it for later. So definitely maybe check out Williamson Health and some of the stuff they're doing across the state. And that's all I have.
Thank you so much, Dr. Wooten. You all were wonderful, and I am looking forward now to looking at the questions and comments from everyone who is participating. So let's get to those. I'm going to start with the Q&A box. It's a good morning. Thanks, Michelle. Good morning to you too. Let's check out the chat box. It looks like it's been rather active. We have some thank yous. Thank you to Dr. Becher. Great seeing Dr. Becher. We are a food pantry, not a health clinic. Okay. That was somebody responding to the poll. I am really enjoying this topic and forum. That's wonderful. So I do have some pre-planned questions, but before that, I would like to give us a moment to respond to Dr. Chaiban. So we did the poll, and some folks hit the box that said sometimes. Can you raise your hand if you hit sometimes so we can give you an opportunity to respond? Anyone? I'm not seeing. If you did, perhaps put it in the chat box. Okay. I'm not seeing it. We'll get back to that. Let's ask this first question. Can you share a little bit about how the topic of food insecurity was addressed when you were in school? Were you ever taught to identify and acknowledge the signs of food insecurity?
I'll go first since it's been the longest since I talked. So as part of a curriculum, I'm going to say no. But during medical school and then residency, I ended up being involved with a few medical school associated things, like working at, we had a mobile homeless clinic that I would work at. And obviously that was an issue there. We were trying to address multiple needs, and food insecurity was one of them. And then during residency, I actually was doing this as part of my health policy fellowship. We were trying to do something down in McDowell County and targeted toward food and nutrition and access. And kind of going back to some of the things I said about hearing Clay, you can't just give someone certain foods and think that's going to solve the problem if you don't know what they have to process those foods. So I had threw this idea out that I wanted to go to people's houses. I do a lot of home visits here in Clay too. So there's no better way to know really how to connect with them and how to give them advice on lifestyle changes than seeing how and where they live. So I wanted to have like a camp stove, a cast iron skillet, utensils to make a meal, all the ingredients to make a meal, and go do home visits with families that used the food pantries frequently in McDowell County. And then you would leave anything there that they needed. If they didn't need any of it, you'd keep it and take it on to the next house. But my program director was like, no, you're not going to do that. So in terms of, was it part of my curriculum? No, I actually think medical education nutrition curriculum is not even that great. I think it's an area that's lacking in my experience. And so I think you get it if you go seeking it out, but I don't really feel that it's in there in a meaningful way.
Thank you. Other panelists want to respond?
I'll agree that it was not part of my undergraduate education at all, especially nutrition, just, barely glossed over. I do think social determinants of health is becoming more recognized as an important issue, especially in postgraduate and doctoral education. So it was addressed in my doctorate program at WVU, probably not as much as it should be, but I think that tide is changing a little bit, and we're seeing how important this stuff is to overall patients' health.
Thanks, Jessica.
It was not part of my education too, and I agree with Jessica that I think the entire nation is shifting toward public health, because if you treat the population, the individual will be saved. And that's why we are now hearing more about topics and discussing them and finding resources and advocating for them.
Thank you. Thank you all three. We have an anonymous attendee asking the question, how can we get information out to our communities about the resources that are available? I just think there are great things that are developed, but they just aren't communicated enough. What do you folks think?
I agree with this comment because I'm one of them. And one of the things I thought about is we need to have like embedded in our medical record, like the reference sheet. There is some, like how you tell people about UTI, when to seek care, when to do stuff, when to call the doctor, when to go to the ER. There should be like, okay, you screen positive. Even if you don't screen positive, it can be part of your like patient information that have resources and phone numbers available that you can include. That's one of the strategies that can be done. Other stuff can be brochures and advertisement boards in the clinic and outside the clinic. Some people won't tell you, but they would call the people to get food or something, but they won't tell you in clinic that they are hungry.
It sounds to me like Dr. Becher has a little better setup at her site, a little bit more organization. My biggest complaint in rural health is we don't have a lot of care coordination or outreach. I would love to have an outreach coordinator where I could go and say, this person is having trouble accessing food. This person needs to get their child screened for preschool. this person is having a baby and doesn't have a crib. Lots of organizations have that person that it's their job to be involved in the community, know what community resources are out there, know how to get people to them. Of course, that's, when you're talking about rural health in West Virginia, we're talking about budgeting and do we have the money to hire a specific person to do that? But that would be so beneficial overall to patient health, especially with nutrition.
I don't have a care coordinator. I don't have a social worker. I would not call my plan organized. I would call it a bit chaotic, but we have a position open for something like that. If anyone listening is a social worker and wants to come be part of my chaos plan, I would love to have you in Clay County. But we do, we post, if we're going to have a big food distribution event, we literally put the flyer up front. It's in exam rooms so that people do see it. You see them, take a picture of it with their phone, write it down. You're right. They may not ask. They may not even be the one who needs it. But they know the people that do, and they're going to either go get food and give it to them, or they're going to get them there. So I think public, social media, although I hate social media, it can be a way to get a word out quickly. If we have an event, a food distribution, or something like that wasn't, maybe it was last minute, didn't get the word out very quickly. Or if it was during the pandemic when our office was, we were mostly doing telehealth, things were put out on social media last minute and people still would see that and get there. So I think social media is an avenue for getting the word out for things and doing stuff like this. There are a lot of people that are involved with getting resources to the people that need them on this exact summit.
Great. Thank you, all three. We have another question. This one is from the wonderful Margaret O'Neill. West Virginia 211 is working on how we can partner with healthcare to provide resources with the EMR. Stay tuned. And so you did mention a bit, Dr. Becher, about your partnership with United Way. Do you want to say anything more about that?
I think that, so number one, I couldn't do half of what I've done without the United Way and the Greater Canal Valley Foundation. And the United Way, they are across the state. And so although I'm working with Margaret O'Neill out of Charleston, there are her counterparts in other parts of the state, and they're a huge resource and really get things done. And so when I think about what is a statewide program or organization, I think there are really, they've kind of got that going on. I think it's just a matter of each person who's tied into the needs in the community connecting with their local person. And I saw somebody posted in the chat that the family resource networks are supposed to coordinate things like that. And they do. Actually, our FRN coordinator in Clay, we will go kind of back and forth. She may be able to help someone with a utility one month, and then I may be out of grant funding another month. And so we work together with helping people get access to the things that they need. And then, maybe she gets a hold of a bunch of backpacks for kids and brings some here so I can distribute some. And so we work together, but none of it's formal. And I think that's part of what people get hung up on. None of these things I've done here are very formal. My community health worker, people always say, well, how do you guys make sure that, what's your workflow? And I always say, we don't have one. She will see me in the hallway and I'll say, hey, there's a bedside toilet in my car if you want to go get that because somebody's going to need it. Just that's how we operate. But, some people need more structure. I just tend to do well without it. So I think sometimes people think there has to be more structure and organization in place to get things accomplished, but you just need to reach out to people and make those connections and then use them and reach out to them when your patients have a need that you think somebody that you've connected with in some way can help.
Great, thank you. We have another question. Is there any area besides Kanawha County running a community paramedicine program? For Dr. Becher to be able to go into homes is amazing, but we also realize the demand for in-house services where practitioners are limited and scarce in certain areas of our state. So panelists or providers who may be on, do you know of any other programs? Okay, and this person gave an example. At my pediatrician's office, there is no resource regarding hunger, no resources regarding hunger or access to resources. And I don't need help personally, but how do we make exposure to access more mandatory? So is there a way, do you think, of putting that into policy?
I think this is a policy thing. It's a policy that's beyond my capacity. But I think one of the things should be tackled is how they look at depression screen. They want us to screen for depression for everybody. They should make us screen for hunger. I mean, it should be part of the screening, part of the wellness visits. And the other thing is making quality metrics for an organization to meet these metrics. It will organization will go to their employees and say, hey, you have to do this or else we're not going to get the bonus. That's on the higher state level. Access resources, I know we have the access, we have resources. Maybe I am not educated about them. They are, but once it's forced by higher above, everything gets done.
I agree. I did see from Barbara Wessels with Unicare that the paramedicine program is expanding to other counties. So stay tuned to our other sessions and on social media to get more elaboration on that. I see in the Q&A, yearly screenings for hunger for all Medicaid CHIP recipients at least once a year. Put it in the documentation. So somebody is making this as a policy recommendation. What do you think about that? Let me read it one more time. Yearly screening for hunger for all Medicaid and CHIP recipients at least once per year. Do you think that would be a viable policy change?
I agree that I think it's to make it across the board to where we're all paying attention to it and we're all doing it out of habit and regularly. It has to be a policy. I come from a place where I don't like when we have policies for Medicaid and Medicare patients versus insurance patients. I like to treat everyone, on the same level, regardless of insurance. So, but like Dr. Chaiban said, it has to be an institutional thing. The institution has to say, we're screening all of our patients for hunger, just like they require depression screenings and BMI screenings. And one of the unfortunate things about it is, from a practice standpoint, is we all work with these electronic health records now. And when if it's not easy to document in your record, if it's not right there for you and you have to go searching for it every time you want to document it, then it tends not to get done as much because it's such a labor intensive thing to actually get it into the medical record, where you used to just write something on paper. Now you're looking for a button to click or something like that. So pulling that into practice, the EHR, and looking at how we're documenting it is also probably going to be an important part of a policy plan.
And I would say, I found like across our different offices, this office has a higher % of social determinant screenings that are done on average. And it's because we have more resources to address them. And so I'm all for there being an across the board, all patients once a year hunger screening, but I would really hope that would either be tied to increasing SNAP benefits, or maybe it would just be data that's then collected and help those payers and whoever above them to see that this is a big deal. It's not just, a small % of people. It's not just the people that are under the poverty level guidelines. It's a big problem, especially in rural areas. And so although all of us in medicine are very hesitant to say, yes, add one more question we have to ask everyone. This is one, some of us are already asking, but you're only going to get out of it what you're putting into it. So if we're not having some incentive or some way to treat that, then it's not going to have the outcome we want.
Great, thank you. So I'm going to ask a question that a couple of you touched on, but I want to kind of elevate it in this discourse because the CEO of Whole Foods came out this week and said that people who live in food deserts across the country are making poor health decisions if they are obese. He didn't kind of blame it on the quality of the food. So how much do you think of a problem it really is, the lack of nutritional food within these communities where there are food deserts? And do you think that there are potential policy issues that we could potentially talk about in session 4 of this series to address it?
I saw that happen on Twitter, like a lot of you probably did. It's insane. I wanted to go back to something that Dr. Becher said. You know, we've been calling these food deserts for a while. That's the term we've been using when you don't have access to a grocery store. But that even verbiage is changing. They're using things like grocery gap now because food desert implies that access is your only problem. The only problem in your nutrition or hunger deficit is that you don't have access to the food. And I think we've definitely pointed out that that's not always the case. Can we get you access is very important. Do you have a grocery store versus a Dollar General is very important. But again, socioeconomic things, literacy, the ability to prepare the food, use that food effectively. So, you know, what he said is crazy because it's not just access. That's not our only problem. And I think any policy change really has to look at that. Can we put a grocery store in Clay and have it be effective? I would love for that to happen. But does that solve all their hunger issues? Probably not.
I would say that access is the big umbrella, but there are barriers to access. If you don't have a car, you're not going to go get it. You don't have public transportation, you don't have a vehicle. Like even if you don't have the public, you don't have your own vehicle to go buy. Other things is one of the things that has been studied and shown that you can limit your food stamp access to healthy food. But there are other things that come with it too. But this is one of the measures that can be taken. You cannot buy anything you want, like not anything you want, but it's not about bulk buying. It's about more nutritious buying. So limitation or restriction to food stamp purchase. The other thing is even if you put the whole food in Morgantown or wherever you want to put it, it doesn't mean people gonna go buy from it. Like Dr. Becher said, you have to give them money to go buy from there. If they are worried or afraid, people are worried to go to something they don't know about or they think they cannot afford. How are they gonna go to it? They're not gonna even try to step into that store. So that can be, you want to do a whole food, could give food stamp that you can buy from Whole Food. That's one of the things I think.
I think that his statement is a perfect example of how we have people at high levels in business and policy making that have never been in any of these places. And so that's really my policy change recommendation. Ask the people that live here instead of making broad sweeping statements about a place you've never lived and never tried to buy food. I guarantee he's never had a conversation with someone who lives in Clay County or anywhere like Clay County, or he wouldn't have said what he said.
Great point. Thank you. So folks, please feel free. We have some time left to put some questions in the chat box. I have some other ones here. If there was one thing you'd like those who manage food pantries and programs that address food insecurity know about how you address hunger in the medical setting, what would it be? So do you have a relationship with the food pantries in your community? And if so, do you discuss food insecurity? And if not, what would you like for those kind of folks who provide that service know about what you do?
We have, so one of our, the Catholic Church in Clay does a lot of food pantry work, and we actually don't have a ton of overlap with them. And I think it's because they've been doing what they've been doing for a very long time, and they're a great resource in the community. And so they're kind of established in what they're doing, and we're kind of established in what we're doing. And so we support each other in that, like, I know that they, they serve a lot of my patients. But I don't ever have the conversations with any of those organizations about the fact that, just because people need food doesn't mean that there shouldn't be some thoughtfulness put into who needs which foods. So, the diabetic versus the heart failure patient versus the person who's underweight, the COPD patient who's kind of cachectic. I think there's a lot of, and they're not assumptions on the part of the people working in these food pantries or organizations that okay, they want food, we're going to give them food, and they're happy with anything we give them. They understand. I mean, they see the same people over and over and know that, like in Clay, chickpeas, no one wants another can of chickpeas in Clay County. But they're really good for you, but no one wants them anymore. We had plenty. So they know that people have preferences for foods, but I don't think we've done a good job about really educating the food pantries in terms of, like, you could utilize everything you're being given if you just shifted it into boxes based on different people's diagnoses. But you get into HIPAA there. It's the patient has to be willing to say, hey, I lost 10 pounds over the last 2 months. I need more carbs or protein. Or the diabetic needs to say, don't give me the orange juice or the pasta. Give that to somebody else. And so I think it's a three-way conversation that needs to happen. I think the patients need to feel empowered to be a little more choosy and to ask, say, can I get twice as much protein and give you all of my carbs because I can't eat them? But in Clay, what I've seen time and time again, the person that goes to the food pantry, they may take the foods they're given, but they're gonna stop on the way home and drop off the pasta at this person's house and this thing at that person's house. So there's a lot of making those distributions happen at the individual neighborhood level, even if the healthcare provider and the food pantry are not communicating about who needs what, which I think is interesting. The patients have worked it out among themselves in a way.
Either panelists like to?
I don't have a close working relationship with our food bank. I've tried to reach out a couple of times. Again, it's staffed and mainly by retirees in our community, and they're not really interested in hearing my patients' health complaints or needs. There's also quite the stigma that maybe we didn't address enough with using a food bank or needing, help with food. And sometimes, our patients don't want to use the food bank because they have to, at our food bank, they have to disclose their financial situation to that food bank. And that's, 10 elderly people from the community that they don't really want knowing their business necessarily. So it's not always the most congenial relationship between the food bank and the people that utilize the food bank. And then they're not always, nothing bad against food banks. They're wonderful and we have lots of wonderful ones, but that relationship just isn't always a super easy one, I think.
That's a great point. Rafka, I think that you turned your...
Okay, I just want to say I don't, and I'm willing, and whoever has any resources in Monongalia or the counties around me, reach out to me. I can send my email. I would be happy to connect. And I already wanted to start a reference sheet for my patients. So, hey, this, just put it there and they will look at it and read it. And that would be helpful, as a start on a lower level.
Wonderful, thank you. We actually have a food pantry provider in your area who'll be speaking next session, so we're going to connect him with you. I'm going to hit a couple of more comments that we have in the chat box. Melissa advised that folks check with their community action agencies for resources in their community, which is a wonderful suggestion. And then Robin asked a great question, but I'm not sure we can answer it in this session. She helped with school meal delivery from March through June and always wondered what actually happened to the food? Did any counties have social workers that help determine families' needs for food use and make referrals? And that's a good question, but I don't think that perhaps our panelists are in a position to answer that one. Did you all participate at all with the food distribution when schools closed, when the at the onset of the pandemic?
I didn't participate. I did talk to our school a little bit to try to figure out, you know, just what was available and what was going on. I can't say specifically what they did, but my understanding is in Jackson County, at least, any food availability was offered to every student. We're a free lunch county, so every student in the county had access to that food. There wasn't, you know, you didn't have to prove income or anything like that, or say you were on free lunch or anything like that. And they advertised it as available to everyone. They did mention that they knew there were specific families who had trouble with food access normally, and they were really making an effort to get that food to them versus having them come pick it up or something at the school. But I don't think that was specific policy or social work driven or anything. I think it was just, you know, some dedicated school members trying to meet kids' needs.
Okay, well, thank you for that. Thanks to all the panelists who have joined us today. This was a wonderful dialogue and long overdue, I think, and I hope that we can keep it going at least over the next few weeks. We hope at the end of this series to get a report that we can get in the hands of our legislators at the beginning of session, which this year will begin in February, and see if we can do something on a policy level to ensure that there are better connections between healthcare systems and food resources. And I really appreciate your time and your honesty, and thanks to everyone who joined us today. We should get this video up this afternoon or at the latest tomorrow morning, and we'll send you a link. And please join us next week as we continue our conversation with the food pantries around the state. Thanks again. Goodbye, everyone.